Welcome, everyone. Good afternoon, and welcome to our session titled Navigating the Landscape of the Opioid Crisis in Newfoundland and Labrador. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador Association of Social Workers. I'll be co-moderating the panel this afternoon along with my colleague, Pam King-Jesso, Nursing Consultant of Policy and Practice with the Association of Registered Nurses of Newfoundland and Labrador. This year marks the 15th anniversary of our collaboration to host a continuing education event for healthcare professionals in the province. Today's session is being offered on-site from the Health Sciences Centre main auditorium and by live webcast. While this event is organized by the NLASW and the ARNNL, we would like to thank the College of Licensed Practical Nurses of Newfoundland and Labrador who have partnered with us for the event today. We would also like to acknowledge the Munn School of Nursing for their support. This session today is being video recorded and will be made available on the websites of our professional associations for future viewing. A huge thank you to the staff from the Centre for Innovation in Teaching and Learning for producing this webcast today. As healthcare professionals, we have heard about the impact of opioid addictions in Newfoundland and Labrador and throughout the country. A recent Agnes Reid poll found that 1 in 8 Canadian adults say they had a family member or close friend become dependent or addicted to opioids, and more than 1 in 4 Canadians saw it as a crisis. In this province, we know that opioid-related deaths are a reality, and fentanyl, which is 50 to 100 times more potent than morphine, is heightening concerns. There is no doubt that this is a complex health and social issue that affects all of society. All income levels, all demographics. As a province, we are moving in the right direction and taking steps to enhance capacity for education, early intervention and prevention programs, treatment options, and support for those impacted by opioid addictions. We have 4 stellar panelists joining us for the presentation today, and each brings tremendous knowledge and expertise in the topic area. The panelists will explore the nature of opioid addictions, what we as healthcare professionals should consider in our work, some of the trends and societal impacts being seen from a policing and community perspective, how harm reduction fits in the model of care, and initiatives that the province is introducing and implementing to address this issue. The format for our session today will consist of 4 presentations followed by closing remarks from the panelists if time permits. Our panelists have a wealth of information and experience to share, and while we will not be having case studies or a question and answer period as in previous years, we encourage you to keep the conversations going with your teams and colleagues on how this information relates to your practice. So now I'm going to introduce our panelists. Trina Snook, on my far closest left, is a nurse practitioner who works with Eastern Health in the field of mental health and addictions. For approximately 20 years, Trina has been practicing as a nurse practitioner in various capacities, with not only her present employer, but also with Central Health. In her current position as a nurse practitioner at the Recovery Centre in St. John's, her main role is to provide withdrawal management services to clients admitted for drug and alcohol addictions. As an advocate for addiction services, Trina is an active member of the Canadian Society of Addiction Medicine. She also serves on the Nursing Practice and the Nurse Practitioner Standards Committee with the Association of Registered Nurses, and has been actively involved with the Opioid Treatment Working Group with the province of Newfoundland and Labrador. Trina has completed the BC Online Addiction Medicine Diploma Program and has recently obtained her Opioid Dependency Treatment Certificate with the Centre for Addiction and Mental Health. She thoroughly enjoys her work and hopes to further her career in the field of addictions. Next to Trina, we have Sergeant Steve Knight. Sergeant Steve Knight is with the Combined Forces Special Unit, which is an integrated unit comprised of RCMP and RNC members to investigate interprovincial drug trafficking and organized crime. Since joining the RNC in 1994, Steve has had varied experiences. As a constable, he worked as a frontline patrol officer for 10 years before accepting responsibilities as the RNC's full-time drug education officer. In that position, he collaborated with social workers from Eastern Health's Addiction Services to develop and deliver various presentations related to substance use and abuse. He delivered over 100 presentations reaching all regions in the province and completed various training initiatives related to addictions provided by Eastern Health and the RCMP. Steve also worked with the RNC's Drug Investigation Unit, where he gained knowledge and skills to drug enforcement. During his 4 years as a drug investigator, Steve was involved with countless seizures of illicit drugs, including marijuana, LSD, cocaine, ecstasy, and meth, as well as prescription medications, including various opioids, benzodiazepines, and stimulants. In 2011, he was transferred to the Major Crime Unit to investigate crimes against persons, which included murder, attempted murder, serious assaults, prison riots, extortion, and sudden deaths. A high percentage of these investigations were reflective of crimes involving individuals in the illicit drug trade. In 2014, he was promoted to the rank of sergeant and assigned to patrol services as a frontline supervisor. And in the spring of 2015, he moved to his current position. Next to Steve, we have Heather Hunt. Heather is a registered social worker with over 30 years' experience working with marginalized populations in both Toronto and here in Newfoundland and Labrador. She's been working as a member of the Street Reach team with Thrive since 2012 in the role of Individual Support Coordinator. Heather works with individuals who have complex needs to support them to address issues or challenges that are impacting on their housing stability. She connects with government agencies, community services, and support networks to advocate for and obtain services and supports that Street Reach participants require to meet their goals and have better outcomes for their overall health, safety, and well-being. Heather offers practical and holistic supports to coordinate and move service plans into action with participants she works with. Her practice is based on a harm reduction philosophy, and she is a strong advocate for social justice. And next to Heather, we have the Honourable John Haggie, Minister of Health and Community Services. Born in England, the Honourable John Haggie completed his medical studies at Victoria University in Manchester. He held several positions as physician, surgeon, tutor, and registrar in the northwest region of England, and after a 2-year fellowship, he received a doctorate in cancer research. Since moving to Canada in the early 90s, Minister Haggie has had a long and distinguished career in medicine in Newfoundland and Labrador. He practiced initially as a general surgeon in St. Anthony with the Grenfell Regional Health Services. In 1997, he was appointed to attending surgeon of general and vascular surgery at James Payton Memorial Hospital in Gander. In 2008, he was appointed Chief of Staff of James Payton Memorial Hospital. Minister Haggie served as the president of the Newfoundland and Labrador Medical Association and the Canadian Medical Association. In Newfoundland and Labrador's 2015 general election, he was elected MHA for the District of Gander and appointed to Cabinet to serve as the Minister of Health and Community Services. So what a wonderful panel we have, and I thank you each for joining us today. I'm thoroughly looking forward to your presentations, and I'll now pass things over to Pam to facilitate this panel discussion. Thank you.
So thank you, Annette. Thanks for everybody for coming today and for those listening via webcast. We'll move right along into the panelist discussion, and I will ask Trina Snook to come forth as our first panelist. And Trina will broadly address the following questions. Is addiction a choice or is it a disease? And what should we as healthcare professionals consider in our assessments and interventions?
So thank you. So I have the task today to hopefully help you to understand a little bit more about addictions from my perspective. So some of the objectives that hopefully you will gain from my piece of the presentation would be to get a basic understanding about the science behind addiction. Also to answer the question, is addiction a choice or is it a disease? And then finally, what should healthcare professionals consider into their assessments and into their interventions? So addictions. When scientists first started studying about addictions in the 1930s, their views were quite limited. So people who had an addiction to drug or to alcohol were thought to be morally flawed. And as a result of this, it helped to shape how we actually treated people with addictions. We took a very punitive approach. We'd bring people probably into a hospital, or we'd bring them into a shelter, and we'd get them to dry out, maybe give them a good meal, a good shower, and then perhaps even a lecture and send them on their way, hopefully thinking that they won't do it again. But scientists really started wondering, what happens to people? Why do people keep relapsing to using drugs like opioids or to keep using things like alcohol? So they started to doing some research into this, to this question that they have, and how we perceive addictions now really has evolved since that time. So we now know through science of addictions that it's no longer a moral flaw in character. It's actually a very big health problem, a serious health problem that in fact costs Canadians more than $40 billion annually. So I guess the big burning question that a lot of people have is, how does a person go from using drugs like opioids recreationally to end up having an opioid use disorder or an addictions? And I'm going to explain this in a very simple terms today, because I know that we have a variety of healthcare professionals here with us. So it's kind of like I explain to my clients at the recovery center. It's like my Dr. Oz version of talking about the brain. And really having this discussion about the brain, or kind of what happens to a person when they use drugs, is very important, because I really want people to take away the message that treatment for opioid addictions is more than just willpower. It's not simply stating, look at what you've lost, you should know better, and go forth. It's a brain disease that is created. And you're going to see from the other presenters as well here, you're going to see how that brain disease of addiction actually manifests itself on the street. You're going to see why there are certain treatments and why there are social workers and other healthcare individuals doing what they do and delivering the service that they deliver. And then finally, you'll get an opportunity to see why government is also investing into this brain disease, why opioid addictions need to be addressed. So first and foremost, I had to say that not everybody who's going to use an opioid will ever become addicted. It really depends upon a variety of factors, things like genetics, things like, do you have a co-occurring disorder like anxiety or depression? What are your coping skills like? Do you come with a history of trauma? But as I always say to my clients who come to the recovery center, you know, the decision to use drugs is kind of like, you might not get addicted, but it's like playing Russian roulette. You really don't know how it's going to end up for you, basically. And the thing is that everybody thinks they're in control of whatever they do. They think that addictions happens to other people. It's not going to happen to you. That's for the other person down the street. But let me ask you this question. Do you really think the hundreds and thousands of people worldwide have addictions ever thought that they would become addicted to drugs like opioids or to alcohol or to other substances? I can assure you the answer would be no. So I do see a lot of people who do come to the recovery center, and quite frankly, they're from all walks of life, like you just heard in the introduction there. And people are flabbergasted that it's happened to them, and they really don't understand it because they always thought they had control over their use. So we'll talk a little bit about that brain and what happens when you go from recreationally using to having an addiction disorder. So what you need to know is that your brain's main purpose in this life is to keep you functioning, to keep you well, to keep you alive. Bottom line, your brain is all about survival. And one of the ways that our brain ensures survival is through a chemical that's in our brain. It's called dopamine, and I assure you that's about as medical jargon as I'll get in this presentation. But dopamine is actually a feel-good chemical that exists in everybody's brain. So you all know that as humans, we need to eat to live. We want to live another day, and also we want to ensure the continuation of the species, so that we have to be intimate, ensure that there's going to be children to carry on the species. During these types of activities, the brain will actually naturally release this feel-good chemical called dopamine. And what happens is that the dopamine is released from the brain, goes down a particular pathway. It's called the mesolimbic pathway if you are interested, and basically tells the brain that something important is happening. So that what happens, your brain actually kind of commits it to memory, learns about that behavior, and then ensures that you'll repeat that life-sustaining behavior again and again. So unfortunately, drugs like opioids also affect that very same pathway. So when a person smokes or snorts drugs, it hits the brain within about 7 to 20 seconds. There's actually a huge flood of dopamine, more so than what you would get with the natural rewards if you had a nice piece of chocolate cake, say, for example. And in some research that I've looked at, they'll say up to 10 times, up to 100 times more dopamine than normal. So it's kind of like this. If you think of it in terms of your brain recognizes all this dopamine and says, wow, that's a huge flood of dopamine. Something really important must be happening to my brain. So it kind of like it really commits it to memory and then really motivates that person to repeat that behavior again and again. So you all know, everybody's quite familiar about it. Of course, addiction's not going to happen to me or to you, it's the other person. So people go to a party and they may decide to use some Percocet, some Dilaudid, some morphine for whatever reason. They want to try it out or whatnot. And essentially they do have control in the recreational use. So of course, maybe another party comes along and maybe 2 or 3 weeks later and they do it again. But unfortunately, unbeknown to the person, when there's repeated use, it's kind of like that slippery slope. Everybody still thinks they're in control. It's kind of like it's you don't really realize what's going on to it into your brain. But when you keep using and you still think you have the control, it's kind of like the brain actually starts adapting to this. So to the brain, it knows that's not natural. That's not supposed to be there. All this amount of dopamine, you weren't born that way. So it kind of thinks after you go from party to party or you go from group to group and you try it, the brain then kind of starts thinking like, hey, this must be the new normal. I wasn't born this way, but this is coming quite frequently now. So again, as I go back, and I always say to people, your brain is all about survival. So it's going to do what it thinks it needs to survive. So if it's used to all of this dopamine or is used from the chemicals from the drugs, it actually starts to change. Cells in this particular pathway begin to change in their cell size, they change in their shape, and they actually change in their functioning. So basically, you weren't born with that, and you really didn't know that it was happening, but it does happen. So remember, with all this repeated drug use, when people go out and they think it's quite harmless, the user don't realize, basically, that these brain changes are occurring. And I always tell people, your brain really doesn't need your permission to change or to do what it wants to do, what it thinks it needs for survival. And you can't tell your brain not to change. You can't tell your brain not to get addicted. So it's kind of like the scenario if you decide you eat that lovely piece of chocolate cake and then you change your mind and say, no, brain, don't digest it because I don't want the extra calories. The brain is not going to listen to you. It's going to do whatever it feels it needs to maintain a sense of balance and to survive. The other thing that happens to the brain, in addition to changing cell shape and size, is that unfortunately the natural dopamine taps, for lack of better words, that we have in our brain, that when you feel good, if you have a nice meal or you had a really good run and you're on that runner's high, what happens is that with the repeated use of all these drugs and chemicals and the changes that happen in the brain also unfortunately kind of turns off its own natural taps of dopamine. The reason why I want you to know this is simply because if you have someone in recovery and they're there with you and they've been clean from, say, an opioid for about a couple of months and they're not very happy, and people are thinking, well, what's wrong with you? You just got your life back, you just saved a big barrel of money, you know, your family's coming back into your life. Why are you still like this? Do you miss the high? And it's not. It's just because of all of these brain changes that have actually happened so that our natural taps of dopamine are kind of like shut off. It's kind of like the brain says, I really don't need to work that hard because I'm going to get the dopamine from an outside source anyway. So it shuts it off. So it tends to explain that in that way. So, okay, somewhere along the line, the person who's been using the drugs recreationally then starts to realize, I've spent a big pile of money. My spouse is now on my case because I'm doing this a little bit too often. I'm missing work. I'm actually starting to crave this drug. So they decide that, okay, I'm going to stop. I'm not going to do this anymore. So they try to stop and then realize they can't. It's kind of like where they crossed over from that recreational use and now have an addiction to it. And I always tell my clients, it's like your brain is your super powerhouse, and it's the main job of keeping you alive. If it's gotten used to the effects of opioids and other drugs and has changed to accommodate it, I can assure you that if you take that away, when you try to get in recovery and stop it, your brain goes, hang on a minute here now. I need this for survival because the brain's been hijacked. So you all know that your brain can't jump out of your head and go get the opioids that it thinks that it needs for survival. So it kind of goes like, well, I'm going to make you so sick now. I'm going to give you the really bad diarrhea. I'm going to give you nausea, vomiting, cramps. I'm going to keep you up at night. And I'm going to make you so miserable that you'll eventually have to cave in, go get it, and get me what I think that I need for survival. So your brain's essentially been hijacked. And if you ask a lot of patients, if you work with people who have addictions, they will tell you that when they're at this point, it's no longer about the high. They don't get high anymore. It's about feeling normal because they are so sick without this drug that the brain actually thought that it needs to survive, that it can't go without it. And hence, it's so powerful because, again, your brain is your super powerhouse.
The code red system is now back in service. Please resume normal operations. Attention all personnel, the code red system is now back in service. Please resume normal operations. Attention all personnel, the code red system
Oh, wow.
Please resume normal operations. Attention all personnel, the code red system is now back in service. Please resume normal operations.
I actually forget where I'm to now in this whole speech. Okay, sorry. So basically, it's no longer about the high anymore. You understand people do it just to feel normal and just to feel well. And I've had a lot of clients who have said to me, Trina, if I don't use, I can't get out of the bed because I'm so sick and my muscles are so sore. They're so stiff. I am sick. I can't do it. So you can kind of see where the person went from recreationally using to that of where they had control, fair enough, they had control, to where they now are into an opioid use disorder where they no longer have the control anymore. So to kind of answer the question, is the continued drug use a voluntary behavior? And this was actually one of the slides. I had to give credit. It came from the National Institute of Drug Abuse. I took this information from there. But there's actual brain imaging studies that have been done, what these researchers have done, that have shown that there are actual physical changes in the area of the brain that is responsible for decision making, for their judgment, for learning and memory, and for behavior control. So you can kind of see then when we talk about treatments, it's not simply about willpower. There's actual physical changes. And for someone who's caught up in the cycle of addictions doesn't feel like a decision anymore. It's almost like a necessity. So, just so I could get away from Dr. Haas and look a little bit professional, I decided to give you a nice little scientific picture here. And again, this photo is courtesy of Anne Rose Childress. Again, it also came from the National Institute of Drug Abuse. And I wanted to put this in there because it talks about the memory of drugs. Drugs have a memory. Your brain, again, your super powerhouse has a lovely memory for this stuff. So to just kind of explain this, there's 2 PET scans. And one of them to my left talks about a person who's looking at a video of nature, pretty boring stuff. And then we have on the right-hand side about an individual who was a cocaine user who perhaps been in recovery for several years. And they kind of wanted to see what effect addictions have onto the brain. And just to point out too, although it's a cocaine video, we're talking about this, drugs of abuse affect the same pathway, so we can easily use this slide here. On this particular slide, I do want to point out that we all have an amygdala. It's the craving alarm. You know, when you want that nice piece of chocolate cake, it's the craving alarm that we have. So looking at the person who's probably, if it was me, if I was sat up here and I was looking at a video of a nature program, well, it really doesn't do a whole lot for me. My amygdala, my craving alarm really doesn't go off. But if you look to the right, if I was in recovery from drugs and someone came in now, and again, I'm hooked to a PET scanner, and someone came in and says, okay, you know what? Here's a bag of opiates, or here's a bag of cocaine. How do you feel when you look at that bag of drugs, basically? And I could be there in recovery for several years, and I'd be like, yeah, okay, that's okay, I can handle it, I'm in recovery, I've got this, I'm doing really, really good. And unbeknown to people who have participated in studies like this, is that when they actually got out and the researchers said, come here, let me show you what happened, is that when a person actually sees their drug of choice that they like, their little craving alarm, unbeknown to them, was actually going off in the brain. And this has huge, huge implications, because this helps to explain why people relapse. Even if they've had several, perhaps months, years, days, it doesn't matter, but why they relapse. Because this is a brain disease. This is no longer about that willpower that everybody seems to think is the case. The brain doesn't really give up that easily, does it? So right now, towards the end of it, I do want to have a little bit of a conversation about assessments and interventions for health professionals. I will give you a quick version, because I guess this is a topic in and of itself, and I only have a few minutes to spend with you to try and convince you that this is a brain disease. But some of the things that you need to keep in mind is that you got to ask everybody now the question. You have to be forthright, whether you're a healthcare professional or, like say in the medical field, or you're in the social field, it doesn't matter. You have to ask that question. Have you ever used drugs or alcohol? And this is really important, and because, when I started my nurse practitioner career, and it's almost 20 years ago I've been at that piece of it, I remember one part of my assessment when it came to the social and you had to ask about recreational drug use. I felt really uncomfortable. I thought, oh my gosh. And really, all at that time was a little bit of weed, ash, that type of thing. But we've changed so much, and you're going to see from the other presenters how much that we actually have changed. So it doesn't really matter. What you need to keep in mind is that it doesn't have to be a 20-year-old or 30-year-old. We've had people who've come to us as old as in their 60s and late 70s. So you really have to ask everybody that question now if they're coming in for, maybe it's counseling for an eating disorder or anxiety or depression. Maybe they're coming in for that refill of that prescription opioid that there legitimately has for that pain. You really need to ask that question. Do you use drugs? And then, of course, if they say yes to this, then you want to find out about the other drugs of use that they could be involved in as well. One of the things that I really like, I try to tell people, it's kind of like the quick and dirty version of what you can do, because you don't need to be a medical profession. You can be from any walk of life when you're asking about drug use. And we have this really nice questionnaire that perhaps many are familiar with. It's called the CAGE aid. So people used the CAGE when they were screening for alcohol use disorder. So we now have the CAGE aid. And that's the one that, it's the same questions that you can use for drug use, for opioid use and the other substances. And basically what it is that, do you ever feel that you have a need to cut down on your drug use? Do you get annoyed when people talk about your drug use? Do you feel guilty about using drugs? And do you need that eye opener, or first thing in the morning, do you need some of that opioids just so that you can get up and kind of function normally? And If you do, then that's the opportunity then for the healthcare provider to explore and to have a look at this a little bit more. And I do want to point out to you that when you're talking about addictions, you might not have all the tools with you, or it might not be appropriate for you to get a diagnosis of addictions, but it is possible you can certainly refer them to somebody else who's a little bit more knowledgeable into that area, basically. So this is also part of the interventions and treatments that we have out there, but I wanted to kind of show this slide because it really talks about recreational use of opioids. It is preventable, and that's where the person kind of has control, but as you can see in the middle of the slide, there's a brain, so it's kind of got to pass through that then, and then we end up to the place where opioid addictions is treatable. This is really important why I wanted to put this here, because as we move forward, we know that we have so many individuals in Newfoundland who are addicted to opioids. We've had a huge flood of money. You know, people are traveling up to the mainland. There's oil. There's all kinds of reasons why we have this problem into our province. But unfortunately, it does exist. And you can't just say to a person, stop using. You should know better. You've just lost your house. You're living on the street. Look at you. Unfortunately, that's not how we're going to treat opioid addictions. It doesn't work. And I had a lot of people who come to me, you know, whether on a professional level, on a personal level, say, yeah, but I don't want my tax dollars going there. You know, people should know better. They should exert a little bit of willpower. And I'll always say back to them, you know what? Okay, let's look at it. If we look at, take for example, obesity, we have the highest rates of obesity in Canada. And if anybody knows anything about healthcare, we know that this modifiable risk factor, this one that we had control over, really is linked to a lot of other diseases that we have in our province that we are treating. Take, for example, we have arthritis. There's, lung diseases like asthma can be linked to obesity, sleep apnea. There's the heart disease. There's diabetes. There's all of these factors. People expect to be treated for this. People and their families, they want the treatment. Well, guess what? They should have the treatment. Treating opioid addictions is no different. So when a person looks at me and says, yeah, but you know, they shouldn't have done it, it's like, yeah, well, maybe you shouldn't have eaten that extra piece of cake, or, you know, that type of thing. It could keep going and going, basically. So we have an ethical duty. We have to treat addictions. It is no different from any other chronic disease that we do have. Treatment is complex. I'm not going to get a whole lot into it because I know I'm soon coming towards the end of my presentation, but we do treat addictions kind of from a framework. It's called the biopsychosocial. So we have a lot of healthcare professionals involved into the care of a person recovering from addictions. It's not just a nurse or a doctor, it's involved other people. We have lots of counselors, we have a lot of social workers. I know even at the recovery center, we actually bring dietitian in who does, you know, learning and teaching with people. So it's a big, huge domain that a lot of people need to get involved with. But one of the treatments in terms of the bio or the medical, you folks probably have heard a lot about now in the news. You know, there's the opioid maintenance treatment called Suboxone and Methadone. I won't get too much into it because it's a harms reduction philosophy, but it is a treatment that we do have available. So it's no different when you have insulin or you have other medications. It's the exact same thing. We need to treat people. And people will then say, yeah, but now you're giving them an opioid. You're just substituting it and blah, blah, blah. And I'll say, yeah, it is a substitution therapy. You're absolutely right. But it's a cleaner version. It's a medicine. It'll last 24 hours. And guess what? The person doesn't really get high from this. It just prevents the withdrawal symptoms. And this is important because if you know of anyone or if you've worked with anyone who's been caught up in this horrible cycle of addictions, they've lost jobs, they've lost families, they've lost everything. So when we're giving these opioid maintenance treatments, we're saying, okay, we're going to squelch these withdrawal symptoms so that you have time now, go work on yourself. Get your family back, get your job back, get back into grade 12, learn how to cope, get an education, put all of those pieces of your life back together that have been destroyed by your drug use. And then hopefully the person, it depends, it's all individualized. The person may stay on this for a very long time, or they may decide along their course of treatment that they want to get off the opioid maintenance treatment. It's individualized. Very fortunately, back in October of 2017, that the regulatory body for nurses now have actually included nurse practitioners in the, I guess, the healthcare professional batch who can prescribe these opioid maintenance treatment. They've clearly seen a need that we have an opioid crisis in Newfoundland, and have did a lot of work in trying to get nurse practitioners prepared for this. So, you know, I work at the recovery center and I have my role to play. However, we're talking about many nurse practitioners and family physicians across the province who now have the capability to prescribe the treatments to treat the opioid addictions. The other thing I want to kind of clue up with is, you know, the medicine piece is only one part of it. The psychological, the social pieces also need to be addressed for people into the recovery of opioid addictions. And we have lots of valuable workers within Eastern Health that I know of, and certainly right across the province, who do very hard, good work in terms of individual counseling or group counseling. We have doorway sessions, there's loads of sessions. And I think to quote my social worker who works at the recovery center, there's something like 56 meetings that happen in the city in a run of a week. So there are treatments that are available, and that's all a part of the treatment towards addictions. Just to kind of say that, okay, as you know, I've been introduced as a nurse practitioner at the recovery center. I just want to spend a minute talking about that. My role is mainly to provide the withdrawal management services to the people who do get admitted to the recovery center. And what happens if you feel that you need that service and you want to take that approach? This is a provincial program, so anybody can avail of it. And, you know, the person calls in themselves, the person or their family, usually calling, recognizing that they have a problem and they need some help with addictions. Detoxing is just the very first step towards recovery. It's a whole lot more than that. But if you call the recovery center, you can get an admission. The nurse will do an assessment, and usually within 24 to 48 hours, the person is admitted into the recovery center. And while there, they'll meet a host of professionals. It's not just nursing staff, but we have social workers as well. And based upon the uniques of the person there, you know, referrals can be made to treatment centers, because some people need the treatment centers. And that could be, you know, a referral to Harbour Grace or a referral to Humberwood. Your family doctor, your family nurse practitioner can also do this in the primary healthcare setting as well. But certainly we'd get things ready and we put those referrals out to people. We also have within the province, those are, you know, covered by MCP, but we also have Serenity on the Rock if you're fortunate enough to be able to pay for that service, basically. So, just to clue up, I want to say thank you. And I hope that my presentation has played some small role into your understanding about addictions, and hopefully people then will have an open mind about the treatments that you'll hear government talking about and other healthcare professionals. So thank you.
Thank you, Trina. Great presentation. Thank you for sharing your knowledge and expertise. I know you have definitely convinced me that addictions is not a choice and that it is a brain disease that we as a province have to look at and address. I'll now ask Heather Hunt to come forth as our second panelist. Heather will address several areas as well related to addictions, and she will broadly address the question, how does harm reduction fit into the model of care?
Thank you. Hello, everybody. I was hoping to start today by telling you a little bit about Thrive and how Street Reach came into existence in St. John's. Thrive was established in 2001 as part of the province of Newfoundland and Labrador's Community Youth Network. Thrive works with the community to address gaps in services, build community partnerships, increase awareness of existing programs and services, and conduct outreach to our most marginalized youth and population. Our current innovative programs and services were developed in collaboration with community to address key gaps. Street Reach is a grassroots outreach service that began providing street-level outreach services in the downtown core in St. John's in 2005. We had access to a van through collaboration with the Canadian Red Cross, homemade soups, sandwiches, juices, tea, coffee prepared by staff, true compassion and care for the folks we met, a welcoming space in that small little van. And also we collaborated with SWAP, Safe Work Access Program, to provide clean drug use supplies to individuals on our outreach evenings. Street Reach is guided by the principle of harm reduction and has two main components: outreach and individual support. Street Reach remains a vital service provider in St. John's and continues to be a collaborative community initiative. Some unique aspects of Street Reach include the support across all age levels, our evening drop-in at Gower Street United Church, walk-ins in the downtown core all year round, and seasonal walks in Mount Pearl from June to September. Over the past several years, Street Reach has supported over 1,200 participants who count on us for their basic needs, the sense of belonging in the Street Reach space, and the real support they receive. In addition to providing food, personal care items, outdoor clothing, footwear, telephone access, information, assistance with accessing emergency housing, safe sex supplies, referrals to external services, supportive and caring interactions, we are a satellite site for the Safe Work Access program known as SWAP, and provide safe drug use equipment, information, and support. And we are an official site providing naloxone kits and training to individuals at risk of overdose, and to individuals who are the loved ones of a person at risk or their friends who are likely to witness or respond to an overdose. I began working with Thrive in the Street Reach program in April of 2012. I provide support coordination to individuals who have complex needs and are experiencing housing instability, or who are experiencing homelessness or rooflessness. The participants I work with are not connected to other services and supports to address their needs, or the connection that they do have is limited or challenged with barriers to services. I have been a frontline witness to the growth of what we now refer to in Canada as the opioid crisis here in this province. In 2005, when Street Reach and SWAP began our partnership, we provided 1,234 clean needles the first year. We now provide approximately 500,000 clean needles a year. Opioid use knows no bounds with regards to age, gender identity, socioeconomic or cultural background, or geographic location. The people in the grips of opioid addiction, in my observations and direct outreach work in the community, range in age from young adolescents to senior citizens. Many of the individuals live in the depths of poverty, while other folks are professionals and work alongside of us. People are not using opioids for fun or recreation. The people I've had the honor and privilege to work with are mainly using opioids to self-medicate the emotional and or physical pain that consumes them. Anyone who takes an opioid can be at risk of an overdose, including people who are struggling with problematic substance use, people who use opiates occasionally in a recreational context, are trying an opiate for the first time, are not strictly following the instructions given by healthcare professionals, me and you. No one ever makes a conscious decision to go down the path of an addiction to opioids, as Trina stated. The overwhelming majority of the folks I have met, supported, and or worked with verbalize that they feel a great deal of shame with regards to their addiction to opiates. Stigma is the biggest challenge that we are facing, not only in this province, but worldwide with regards to navigating this crisis. Many people living with substance abuse suffer in silence, all too aware that society tends to blame the individual and view opiate addiction as a character flaw. The stigma is also felt by their families and their loved ones. Opiates have been around for a very long time. Opiates, originally derived from the opium poppy, has been used for thousands of years for both medicinal and recreational purposes. The most active substance in opium is morphine, named after Morphos, known as the Greek god of dreams. Morphine was extracted from opium in a pure form in the early 19th century. It was widely used as a painkiller during the American Civil War. Chemists trying to find a less addictive form of morphine made heroin. In 1898, the Bauer Company started the production of heroin on a commercial scale. From its first clinical trials, it was considered a wonder drug, and its use spread as people discovered that its effects could be amplified by injecting it. In the early 1900s, drugs like heroin were used in cough suppressants. Methadone was first synthesized in 1937 by scientists searching for a painkiller that would be easier to use during surgery and less addiction potential than morphine or heroin. Let's jump ahead to the 1990s. And we see new painkillers coming onto the market with the approval of Food and Drug Administration, specifically oxycodone in 1995 and Percocet in 1999. These are man-made opiates which mimic the body's own painkillers. And now there is fentanyl. It is showing up in cocaine and pills, and it's not only people who use drugs via intravenous injection who are at risk of overdose. Fentanyl is being cut into a lot of drugs. Fentanyl is truly a game changer. Efforts by community organizations, professionals, government, and the larger community to provide meaningful connections and support to folks in the grips of opioid addiction requires a non-judgmental approach of true caring and compassion that meets the individual where they are in their life journey and offers strategies to reduce harm. A basic core value in social work practice is respect for the inherent dignity and worth of persons. Social workers respect the client's right to make informed choices and to have voluntary informed consent. Nurses in all areas of practice and at all levels of decision-making bear the ethical responsibilities identified under each of the 7 primary nursing values. The core values of the professions of social work and nursing complement each other. Our values speak to honoring the dignity of the individuals we serve, promoting and respecting informed decision-making, promoting social justice, promoting health and well-being, and maintaining privacy and confidentiality. We must see people as people, not clients or cases. Avoid judging at all costs because the cost may be a person's life, as stigma felt by them in their interactions with frontline workers will keep them in the shadows. Individuals have a right to non-judgmental education and support. People can play an active role in their health care and overall well-being. Harm reduction principles and practice are a crucial component in providing services, supports, and interventions that will have meaningful, healthier outcomes for people. It is one of the most effective approaches in addressing both health and social problems related to opioid use. Treatments and tools of an abstinence-based approach do not work for the greater majority of people who attempt them or on whom they are imposed. Core principles of harm reduction philosophy recognizes that programs and services must be offered in a non-judgmental and non-coercive manner. Harm reduction strategies are not to be administered punitively. It recognizes the impact of issues such as poverty, racism, classism, homophobia, trauma, social isolation, and other social inequities on people's vulnerability to and capacity for effectively dealing with risk-taking behaviors. We need to meet people where they are when we engage with them. Harm reduction suggests that this work should be focused on minimizing the harmful effects of behaviors rather than focusing solely on cessation of the behavior. Take a moment and ask yourself, how do I look for relief when I need to calm myself, when I am stressed out, when I need to escape the emotional and or physical pain I endure in my own life, when I need courage to face difficult things or people, when I feel pressure in social situations, when I cope with feelings of loneliness, when I feel isolated. Now imagine that those coping strategies, whatever they might be, are taken away, and you are told either subtly or not so subtly by one person, a dozen, or thousands, that you must cease immediately and that you were doing something that a lot of folks don't approve of and frown on. There are even slang terms to describe you. What lengths would you go to get it back? And in some degree, shape, or form, how would you feel? Harm reduction strategies encourage people to reach out and connect. It recognizes the very act of doing so as a strength and mobilizes their self-confidence. Harm reduction supports the shift from total chaos to an experience of feeling a sense of control in one's life. The outward manifestation of an addiction reflects inner pain. At one time, the opiate did provide relief when other coping responses were not available or known to the individual. To quote Nancy Poole of the BC Centre of Excellence in Women's Health, every problem was once a solution. The temporary solution to physical and or emotional pain and or trauma was at one point in time a solution for folks, but that quickly whittles away to feeling physically ill and unable to cope or even function without the opiate. IV drug use is, in and of itself, traumatic to most individuals engaging in it. It is extremely important to not re-traumatize the individual through service provision. Individuals who use opiates carry a great deal of self-stigma. They are more likely to avoid treatment. The language we use to address people who use drugs can contribute greatly to their feelings of shame. When they internalize these terms for themselves, they are likely to experience self-stigma and believe that they cannot recover. Unless we can reverse the effects of self-stigmatization, the people who experience it are unlikely to facilitate change in themselves or seek help. Research has shown that language influences cognitive bias. Use people-first language. Refer to the person before describing their condition or behavior. For example, instead of saying someone is a cocaine user or addict, try a person with a cocaine use disorder. When we describe people as addicts and users, it labels them, dehumanizes them, and makes it very easy to make generalizations. This creates barriers in communication and treatment. Use language that reflects the medical nature of substance use disorders and treatment. Terms such as substance use disorder and addictive disease focuses attention on the medical aspect of the disease. We use language that promotes recovery and hope. Avoid slang and idioms as the negative connotations are significant and contributes to shame and self-stigmatization. Avoid these terms and phrases even in private settings or speaking with your peers, as it can really have a far-reaching impact on your practice. Test results should be reported as positive if substances are detected and negative if no substances are there, not dirty or clean. There is an urgent need to move towards more respectful language so that we are not contributing to stigma, marginalization, and poor outcomes for people who reach out for support. By providing clean drug use supply through Thrive's partnership with SWAP, I have directly witnessed the reduction of negative consequences of opioid use on a person's health and overall well-being. Providing safe works access can and does clear a pathway for people to engage with our staff, our volunteers, and other service providers to begin addressing some of the underlying issues that are at the foundation of commencement of their use. Walls of isolation are eroded through safe works access. People begin to feel like they do indeed belong and that they matter. They are seen, supported, heard, respected, and served. Harm reduction practices for people is more often than not life-altering. I have been witness to people making the decision to work towards cessation of opioid use and engaging in supports, services, and treatments offered both in Newfoundland and outside of this province to make their goal of an opioid-free life real and sustainable. The Provincial Opioid Implementation Plan adopts harm reduction as a foundational approach to the provision of mental health and addiction services in this province. Without the continued support by government to provide funding to frontline agencies such as the AIDS Committee of Newfoundland and Labrador and Thrive, we would not be able to carry out our mandate. Harm reduction needs to be a community initiative in which many are involved in supporting. It helps to curb diseases, reduce healthcare costs, promote social welfare, responds to societal changes, and respects people's human needs. Access to harm reduction is a health right and a human right. Progress with removing barriers and reducing or abolishing stigma will go a long way to support people in taking the necessary steps to health. Supervised consumption facilities prevent overdose deaths and other harms by providing a safer, supported environment for people using substances. If we build it, they will come. People are dying from highly preventable diseases and conditions. A supervised consumption facility would support and educate people at high risk. In St. John's, we are extremely fortunate to have the Safe Works Access Program. SWAP distributes clean needles and other harm reduction supplies and educates people. They also provide the safe disposal of supplies and not only provide disposal receptors, but will also travel as far as CBS to pick up and safely dispose of used supplies and provide new clean ones, plus education and non-judgmental support. They also provide evening outreach on Tuesday and Thursday nights. They are located at the AIDS Committee of Newfoundland site at 47 Janeway Place. Their phone number is 757-SWAP or 7927. The harm reduction manager is Tree Walsh. She's an amazing human being, very approachable. I would encourage you to connect with her at any time if you have concerns for somebody or you'd like to get them connected for clean work supplies and education. The Indigenous Friendship Center in Stephenville has partnered with SWAP, and they support folks in the Corner Brook, Stephenville, and surrounding areas. You can also call for SWAP support in Corner Brook by dialing 634-SWAP. Citizens of Bell Island have formed a Facebook group known as Heal Bell Island. Their Facebook space offers a place for people to discuss the island's drug problem and ways to combat it. They have started the In Good Hands outreach service. The trailer they have is a welcoming space staffed by volunteers who provide clean needles and education materials to support people who use drugs on the road to recovery. Naloxone is an antidote to an opioid overdose. It temporarily reverses the life-threatening, slowed breathing from an opioid overdose. Naloxone, also known as Narcan, became available free of charge to individuals who use substances, their loved ones, and friends in December 2016 through the initiatives of the provincial government. In St. John's and surrounding area, people can obtain a naloxone kit and training on how and when to use it through Thrive at 108 Le Marchant Road from 9 a.m. to 4:30 p.m. Monday through Friday, and at our outreach services at Gower Street United Church on Thursday evenings from 7 until 10. The AIDS Committee of Newfoundland and Labrador has a fantastic website which includes a great tool to locate sites providing naloxone throughout Newfoundland and Labrador. I have 5 minutes or less left, so I'm going to skip a little bit here, and I'm going to talk a little bit about Narcotics Anonymous, known as NA. It has a presence in this province. NA is a global community-based organization. They offer support from peers in a group atmosphere and offer ongoing support networks for people who wish to pursue a drug-free lifestyle. Membership is free, and if you go online to view the official website of CARNA, that's Canada's Atlantic Region of Narcotics Anonymous, you will find contact information and a list of local meetings in Burin, Carbonear, Corner Brook, Deer Lake, Gander, and St. John's. I would highly recommend that you take time out to view the online resource towardtheheart.com, a service of the BC Centre for Disease Control. This is a fantastic website for individuals, families, and professionals that includes a new online e-learning lesson outlining what to do if you witness or suspect an opioid overdose. Take the naloxone quick learn lesson. The Canadian AIDS Treatment Information Exchange, known as CATI, is another treasure trove of resources for professionals and individuals. I would also encourage you to read the reports and research by Nancy Poole, that's Poole, about the use of prescription pain medication by girls and women, focusing on the links to experiences of trauma and chronic pain. In closing, I would like to quote one of the Canadian leaders in harm reduction education, Mr. Walter Cavallere. What may keep Canadian harm reduction honest and effective is the inclusion of people with the lived experience of drug use in all phases of policy development, programming, from design through delivery, through evaluation and research. Thank you.
Thank you, Heather, for sharing many great resources that individuals and healthcare professionals can utilize, and thank you for sharing your expertise related to harm reduction strategies. So I'll next call upon Steve Knight, who will come and address societal impacts and speak to societal impacts and trends that we're seeing as a result of addiction to opiates.
Good afternoon, everyone, and I'd like to thank the panelists, the other panelists that are here before me today, and I want to thank you for the opportunity to speak before you guys in relation to this training initiative that you've put forward. I want to very first clarify the fact that I don't consider myself to be an expert in anything that you're speaking about here today. I am a police officer. I fall into the pillar they're talking about, and one side is a little bit unpopular at this point in time, but is enforcement, and that's where I find myself speaking about it. But as said, I'm a police officer with 22 years of police experience. 9 of that has been dedicated in one way or another in relation to drug enforcement and drug education. I spent 2 years as a drug educator, and where I gained the knowledge I got from that, as previously said, was with Eastern Health. I worked with their addiction services. Great people. I learned a lot there, but I had the opportunity to speak and deal with people with substance problems, substance addictions, and gained a lot of information from them. So in preparing for this today, what I was asked to do was to speak about what trends are out in society today. And so I moved forward and talk a little bit about what we're seeing out on the streets from an enforcement side of the situation. So before we get right into that, though, I'd like to speak a little bit about some of the terminologies that we often see out there back and forth. And so very often in society itself, medications for the average Joe consider something that's, some of the substance used to treat or prevent an illness. While the word drugs itself is often used to an illicit form of substance for persons to get high for mood-altering characteristics. If you talk about the youth today and you're thinking about medications, it's good. If you think about drugs, they think it's bad. Well, as we both know, what we're seeing on the streets right now is that often good medications are being misused in a bad way. And hence what we're talking about today is opioid crisis, and that's where we're going down that path. Tolerance itself is a key word in all this. In relation to it, occurs when the body becomes accustomed to the drug's presence and it builds resistance to its effects. That cause the user to use the increased dosage to try and get the desired effects, chasing that first high, as Trina alluded to back and forth. One such drug that uses an excessive amount of dopamine in the brain or creates the floods of things is meth, crystal meth itself. We see the crystal meth out there floods the brain with dopamine, and people, it just completely hijacks the brain to the fact that the person can't function without thinking about anything else about how to get that high. So relationships, family, things of that nature, just well-being, food, things of that nature have no concept to them. It's about chasing the high and getting what they need to get that high going. So eventually the user takes the drug just to try and feel normal. And I think Trina alluded to that, and it was a big form of understanding for me. The Johnson model of addiction just shows that when a person's normal and they start to take drugs, they're chasing that high, and the body starts to build tolerances to it. And in a drug, as you start to come down, you never go back to the normal feeling. You never hit normal. You always fall below it. And for people who don't misuse drugs and often drink alcohol, it's the hangover effect. You think about a person that drinks, and then they go into that, a little bit, oh, I drank too much last night, I got a bad headache, and everything else too. And next thing you know, after a little bit of time, your body comes back to the normal situation. Well, for drug users, it doesn't come back there. We see that depression is a fall safe for a lot of people with these individuals that have these substance abuse problems. They fall into the category of depression speak there. So they start to use the drug again. You never quite keep reaching that high. It's a chase. And as you can see by the graph that goes back and forth, that eventually people who are using opioids are just trying to feel normal. That's an underlying characteristic. If you speak to these people, that's where they are. If you've ever seen, I'm sure everyone here has Netflix, or most people do, there's a very interesting documentary there. It's a 4-part series called Dope. And in that situation, you'll see, and they speak to addicts, and they go through people that have these addiction problems. They talk about it. People of everyday walks of life, normal people that got hooked in the opioid crisis at the time, have now become full-blown street use addicts. And it's a very difficult position for them. They've lost everything in their lives. So the withdrawal aspect of it creates symptoms that could be the opposite effects produced by taking a drug. Again, I qualified it, I'm not an expert in this, but when the OxyContin epidemic came through in the province of Newfoundland and Labrador, OxyContin, as you know, was a wonder drug that was created for terminally ill patients. However, when misused, when you come down off it, it creates the opposite effect. So OxyContin was used to mitigate pain and avoid pain and pain management, but when it's misused, it turns around that people were causing a great deal of pain. So now they're in so much pain, they're trying to use the drug again to keep going. So one of the leading causes of addiction is people take more drugs to withdraw. So currently, the street drugs that we're seeing in Newfoundland and Labrador are listed up above there. We're seeing some, obviously there's a fair amount of marijuana in the province, hash and hash oil, shatter, coke, cocaine, crack cocaine, heroin, ecstasy, there's Molly, there's a whole bunch there listed out. As you can see though, the prescription medications, the opiates are out there, and there's a fair amount of these on the street. And we're going to talk a little bit about that and how this is all, some of the street drugs have led to the opioid problem we find today. So I'm not here to get into people's opinions and what they find about marijuana. That'd be a dangerous slope for me to go in this current climate. But what I will say is that I from a police officer's perspective, and I welcome my people's, their perspective on how things are in society today. Marijuana, in my opinion, and from my experience, is truly a gateway drug. That doesn't mean that everybody who uses marijuana is going to become on to go harder drugs. But when people say that marijuana doesn't have addictive qualities, I don't really think that they've done enough research to make that statement. And today in society, we're seeing a lot of marijuana out there, and I'm not quite sure that we are ready to take on more problems with the one legal drug that is out there now is alcohol, and we have enough issues with that around it too, and do we have enough programs in place to help people? And now we're going to introduce another drug into the situation. So I'm not saying that it shouldn't be legalized. I would rather see it decriminalized. That's just a personal opinion from a police officer with 22 years experience. But I will say that it's going to bring some problems into our society, and I'm not so sure that we're ready for it as it's coming. But it's being forced upon us, and we have to prepare for it. But for people who want to talk about marijuana just for a brief second, THC, technohydrocannabinol, is the active ingredient in marijuana that gets people high. My generation, when people were going through, THC content was between probably 5 and 6%. Today's THC content in the marijuana that's out there is between 15 and 20%. And does anybody have any suggestion why it would be that way? I know it's supposed to be Q&E, but I always like to get the audience to agree. Anyone have any thoughts of why today the THC is much more potent than it was 25, 30 years ago?
Tolerance and money.
Pardon me? Tolerance and money?
There's more money to be made now in good weed.
So how do we increase the THC in the drug?
How do we increase it? I'm not sure how it is increased, but it's what is in demand. Like when people
Yeah.
go to buy it, they're not looking for the lower THC anymore.
Well, the lower THC doesn't even really exist. And what I'm alluding to is that it's hydroponically grown. So it's grown in a controlled atmosphere where you have a cycle of lighting that happens every 4 to 6 hours. So it changes daylight, where marijuana is a natural plant grown in society. You'll find now that this situation where it's grown hydroponically indoors, chemicals are added to it. The THC content has now gone through the roof. And with a drug that is the bottom one there in the picture is shatter. Shatter itself is still marijuana. It's the way it's processed down and gets to become shatter. But the THC content for shatter is 80 to 90%. That's extremely high, which then you see by the prices. If you said weed sells on the street for $15 a gram, okay, you're talking the shatter sells 50. You can see the difference in price, how it goes up there. So again, we talk about marijuana, now we're going to introduce edibles into the situation, and no one's going to be able to regulate to see how much is in this drug. I guess it's a topic for a different day, but I am concerned as a police officer and as a parent for what we're going to see in marijuana. Well, acid has been in the city and in the province for a long time. It's never really super popular like marijuana. It just comes in waves back and forth. And you see this is both things here are blotter paper acid. And it's on the printing ink that comes across the screen, little types of squares taken and put on the tongue, and it creates that euphoric effect. Hallucinogen, it's a strong hallucinogen at that. $5 to $10 a pill, and they can cause serious and lasting mental illness. And so LSD is something that we see there, but it's not super, super common. It comes in waves. Ecstasy is something that we've seen in the past too that had a strong grip into the 2010 area, up to 2015. There was a lot of ecstasy on the street. Right now, we're seeing more of the Molly, which is more of a different chemical component to it, MDMA and MDA. Molly is out there now and is out there. It looks a lot like cocaine, so people would see it and not sure they can differentiate. I'm taking Molly or I'm taking cocaine. Very notable here, you can see that the high lasts for 1 to 4 hours, and is known as the love drug, or it's a club drug. People like the bright lights and things of that nature, so the downtown scene where your bars are out there and you have a lot of bright lights flashing and everything else, so that's therapeutic, if you want to call it, or it creates a euphoria. And many people don't understand, but it's known the love drug for many different reasons, because it's often used as a date rape drug. People are touchy-feely in a situation when they're using ecstasy. They like to be touched. It's all part of the process and how you feel, and which leads to, it lowers people's inhibitions, and next thing you know, things happen that may not have happened if you weren't taking such an illegal substance. We do see it on regular things in the street here, and you can see the tablet runs between $5 and $10 as written on the screen. Cocaine is probably one of the biggest drugs we have, illicit drugs on the street at this point in time. It's very, very popular in our province. We're seeing quite a bit of it. We have some concerns in the amount that it's there. The minute we take one dealer off the street, there seems to be 2 people want to fill its void. The amount of profit that people are making from this drug and the way they're cutting it, and most people are familiar with the word cut. What they do is they take actually, that's a slide coming into it, but basically, drug dealers' profits, that's their only motivation is money. They're not worried about people's health. So when we talked a little bit about fentanyl and how it's coming in here, that's alluding to drug dealers and how they're expanding their profits. And sometimes they're killing their clients. And it's not a concern. And that's very difficult for people to understand, including myself. But a lot of times people are chasing that high, and no matter what it's cut with, they're willing to take the risk. And we can allude a little bit more to that. Pardon me?
They sell more if someone dies.
Actually, that's a true statement. They sell more sometimes if someone dies, because now people are saying, wow, this is a crazy drug. And it seems to build a hype around it, which goes back to Russian roulette, I think that you alluded to earlier. So cocaine itself, the effects, it's snorted, usually lasts between 1 to 2 hours. I don't think it gets much longer than that. But crack cocaine, smoked, only lasts between 5 and 10 minutes. And the dopamine that's released compared to crack versus just snorting it is completely different. Hence, the high is so much better, so I'm told, in relation to crack cocaine. It's more expensive. It's not very difficult to make from ordinary cocaine, but there is a process to it. And so it's a smokable form of cocaine, which is ingested or is inhaled much quicker into the body. The key note I have down at the bottom, like you see, it sells about $80 a gram for $2,100 an ounce. All it runs, the more you buy, the cheaper it gets. So if you're a drug dealer and you want to bring in a kilo of coke into the province, it'll probably run between $50,000 and $60,000. And you can do the math back and forth. They're at $80 a gram. If you're a dealer that can sell by grams, you're going to sell it, it's 1,000 grams. That's a long time to make that profit back. There's a lot of, what you do is you fan it out to other people to help you sell it. And when they do that, everybody takes a cut. So if I get 2 ounces from a reputable dealer that I think is good cocaine, well, I want to expand my profits. I take that 2 ounces and I cut it with some other different agents to make more of it. So instead of having 2 ounces, I have 3 ounces. But the quality of the drug is now diminished. And that's how you get down. So the lowest levels of street use you'll find is the poorest quality of cocaine. So purity is inconsistent due to various cutting agents, and that's really what's popular, my point I want to make here. So if we move from these drugs into the opiates, and what I call, what we're seeing out there is codeine, morphine, oxycodone, hydromorph, methadone, fentanyl, and heroin. And we'll break this down a little bit and just show you what the goes. Codeine, for example, on the street, Tylenol 3 or Addisol 30s, run between $3 and $5 a pill. Morphine, 15 milligrams, runs for $8. Oxycodone generally runs for $1 per milligram. This is street prices, obviously, folks. Dilaudid, runs between 15 and 35, depending on potency. And fentanyl patches can be very pricey on the street, between $60 and $500, depending on its quantity. So you can see these drugs are very, very popular, and so much so that we have a problem enforcing it because there's so many scripts that are written out there in relation to these drugs that are on the street. We're concerned with the way it's going, and I guess so I guess we'll get to that second part in a second. But why are opiates abused? Some of the other panelists have already spoke about this. Trina did, in fact, to its euphoric effect to mitigate pain. I have it in red there as avoid withdrawal. It gets to a point that people are so addicted to this drug, they don't want to go through experience of anything known, as related to as withdrawal. It becomes very, very problematic. But why do they use it? Consistent dosage. Street drugs out there. If we look at OxyContin right now, which hasn't been produced since I think 2012, but yet OxyContin 80s still make it to the street. And people, it's not a hidden secret that OxyContin is no longer made. It is. It's out on the street. So what is it? It's fentanyl. It's not a question of what it is. It is fentanyl. We know that we've seized this drug. We come back. We send it for analysis. It comes back as fentanyl. But yet people are still believing they're taking Oxy 80s. So it's an expensive, endeavor. But people get involved. They think they're taking a consistent dosage of a drug. But if it's not Oxy 80, which is not made, as I said, the consistent dosage with fentanyl is not consistent anymore. It's removed from that aspect of it. Now they're playing Russian roulette. You don't know how much fentanyl is in the pill you're getting because there's no regulations to it. So factors that lead to opioid abuse. Up there, I said I don't really have a super lot of knowledge of this because it started long before I was, into policing that. But the pharmaceutical companies started to introduce these powerful drugs into society, and they were pushing it hard. And the physicians that were taking these were given that the FDA, the Canadian Drug and the Canadian Drug and Food Association or network that minister the situation about what's regulated in society. they approved these drugs, so they're now in the market out there and everything else too. And these pharmaceutical companies were not so sure on the addictive qualities were taking place. So they were pushing these drugs out. The doctors then were writing these scripts, and there was no second thought about what was coming after. And now, as we see from the OxyContin crisis that we went through here, that there was a major issues around this, and it led to eventually that I think society today is much more prepared for it. Where there's a lot of conversations about controlling the medications that are out there with the prescription drug program that the province is unrolling, things of that nature. We're much more aware of it, but at that point in time, so much of these drugs are out there, it was hard to control. A script for OxyContin on the street in 2004, 2005 was running for about $500. Didn't have to be filled, you just had to have the script in your hand. So those kind of money out there, this was crazy. And what changed is typically drug trends work west to east. Whatever happens out west eventually comes east. However, with the OxyContin thing, when it unrolled, it was east moving west. So we were getting calls from Calgary and Edmonton and Vancouver saying, what's this drug? What's this about? And we were kind of on the cusp of where we were trying to enforce this measures and getting out there. So it was kind of different. It was us, Cape Breton, Nova Scotia area was where it kind of started, and it moved west. So that was kind of a different situation. When we were seeing fentanyl now, when we're talking about it, fentanyl is moving west to east. So heroin is a drug that, for some reason, just like crystal meth, has never been very popular in Newfoundland. It doesn't mean it hasn't been here, it's not being used, it is, but it's not extremely popular. And I really don't have an answer for that. I thank our lucky stars that it's not here and not here as prominent as in other locations, but there is major issues with heroin. The recent seizures of heroin that we had here came back as fentanyl. And hence we're seeing the amount of overdoses that were coming through, emergency, everything else too, and then the conversations that was alluding to in the fact of the deaths we're getting out there. And I do have some statistics from the Chief Medical Examiner's Office in relation to deaths in the Newfoundland and Labrador, and I can compare that back and forth with British Columbia. So we're seeing out there, it's $80 a point, which is 1/10 of a gram heroin is on the street. And again, the appetite for it is not as popular here, but what we're concerned about is the poor quality heroin that's being shipped to Newfoundland, mixed with fentanyl, and then being sold as a high quality heroin. And then people who get addicted to this drug, then continue on. Heroin is often a drug that's associated to street use from people with other opiate problems that can no longer fill the legal prescription pills that were out there. So they're moving from your OxyContins, your things of that, and your hydromorphs in that way. When they can't get those, they start moving into heroin. So there's something to be said for the medical correlation to try and use the ability to get people off these drugs in a safe, less harmful manner before they get going to street drugs. So what do we know about fentanyl? It's a synthetic opioid. It mimics morphine. It's 50 to 100 times more potent, and it's transdermal, so you can touch it through your skin and it'll be absorbed into the body itself. From a police perspective, it's very concerning for us, for healthcare officials, paramedics, nurses, physicians that are in the emergency room back and forth. This is problematic because they're concerning about how much is there. As you can see by the little vial there on my right, I think your left would it be, the carfentanil on the right side. Very little of carfentanil is required. And as Dr. Haggie and I spoke this morning on CBC radio, you know, an envelope full of carfentanil could kill most people in this room, which is pretty scary when you think about it, but these drugs are out in our society. It's 100 times stronger, carfentanil is, than fentanyl itself. So explaining the profits, this is what I alluded to a couple months ago, expanding the profits. So if a drug dealer picks up a key of cocaine for $50,000, he takes it, he opens it up, he adds fentanyl to it, he uses a cutting agent like dextrose as a sugar base, and mixes it all up, he has the opportunity to double his profit. And this is done all the time. So the drugs that are out there are, very unlikely you're going to find 100% pure cocaine because everybody takes their cut. As each person moves down the line, they take their cut of what their profits are going to be and increase them. Not sure what happened there. So the introduction to fentanyl into drug trafficking, as we can see, this is an opportunity, this drug, to take extremely poor quality cocaine, heroin, things of that nature, add fentanyl to it, increase its potency, and get it out onto the street. What we're seeing is people are using these drugs that are often overdosing because they're not sure of how much drug they're taking. So you go in, if you're a cocaine user and you take 3 to 4 lines at a given time, and you take 3 to 4 lines that has an excessive amount of fentanyl into it, next thing you're into a respiratory problem, you can't breathe and everything else too, and without the drug, not naloxone and Narcan, you're into a situation where you may not make it through. And this is why it's so important that drug is out there to help self. I think that we need to do a more positive education role in here. This is something that came out of the Alberta Health Services, and it's getting out in front of these things too. And I think we're starting to make that inroad, but we have to educate everybody. That's where it's going to start, especially with our youth. So often these kids today are going to attending parties. They call them farm parties. And it's nothing to do with the farm and the ghouls or going to somewhere with it's nothing to do with that. It's where everybody comes with a handful of pills from their own kitchen cupboard or their bathroom cupboards, throw them into a bowl, everyone has a few drinks, and then let's see what kind of pills we take, right? So that's obviously a concern where we are too. So education is a major component. Obviously, I like to talk. You can sell that, so I'm way behind on my slides, so I'll pick it up a little bit. This is an officer safety warning that I do when a fentanyl presentation to patrol officers to ensure that they know how much is out there. The one analogy in this here, I think this thing, if you took a business card, standard business card, and you ripped it up into 1,000 pieces, and you put it into a situation, imagine 1,000 pieces of a simple business card. 2 pieces of that 1,000 could be lethal, and that's why they look at back and forth there from carfentanil. So the personal protection that patrol officers and police officers are given right now, you can see as a clandestine lab investigator. So if we have a lab where there's drugs being made, level B is the most situation. A full CBSA is required there. We have our own kits, but we're into a drug situation. We call the paramedics out with us. We know it's there and we're active, but the people who are using these drugs often are not in a situation where they don't have that luxury there, and this is why Narcan and naloxone is so important to be around. Brace for impact, I have there British Columbia 2016 stats showed that 1,422 people, I think in total was, overdose deaths confirmed in BC, and 1,156 of them detected fentanyl in those statistics. 73% increased deaths from 2016. So that, BC is looking at a serious, serious problem out there. They recognize it, they're out in front of it, they're doing everything they can to combat it. Newfoundland and Labrador itself, we had 23 accidental drug doses last year involving opiates. 2 were still under investigation by Dr. Avis, so it could be as high as 25. This is polydrug use, and in fact, it's not just one of these drugs. A lot of times there's a mixture of these, and I had different statistics there for it. But you can see that in the 23 deaths, fentanyl was detected 6 times, right? And 1 was carfentanil. And that 1 carfentanil was in Labrador, and it was a drug in a small community where the drugs were shipped in. You don't know what you're getting when you order from the web. Statistics for Newfoundland opioid-related deaths from 16, as you can see, they've increased from 2009 to 2016. And Dr. Avis, shared his concern that the opioids are out there, and we're going to start seeing more of this, and we have to take some action. The social impacts that are coming out there back and forth, I don't think it's I'm waving to say that from my experience, about 80% of the crimes that occurred, and this is not a statistic for unearthing, so I was saying, but about 80% of the crimes that I've seen throughout my career are somewhat related to substance use and abuse. You're talking about break-in entries, your thefts, your assaults, all those things back and forth usually happen a lot of the time because someone's under the influence or looking to be under the influence. So armed robberies we're seeing out there. When you owe if you have a drug addiction that's costing you $400 to $500 a day, you're not sustaining it. It's not possible. So what happens is people allude to criminal acts. And often it's stealing from family where it starts. Next thing you know, you're stealing from your neighbor's car. Next thing you're doing a break and entry up the street. But this addiction consumes you. I really love the terminology that opiates hijack the brain, because that's really what happens, because rational people don't do those things. But when you're desperate, you do what you have to do to survive. And what happened, we're seeing armed robberies as a step up. You're using firearms, you're using knives, bats, anything you can do to facilitate getting that money. I have home invasions there. The concern for home invasions is not so much, it is sometimes people using to get more drugs, but these are often drug dealers looking to rip off other drug dealers. That's where you're seeing that, and the level of violence that goes with that. Who knows? We've seen it. There people have gone into houses. They've kidnapped people from their houses, and people have died as a result of these things. So some of the societal impacts that we're seeing, obviously a person's individual health, their finances, relationships are all caused enormous grief. And society itself, our healthcare system is burdened, is taxed beyond belief. I think Newfoundland itself, we're such a big geographical problem, such a small population, we're trying to do what we can to make sure that we can get these messages out to help people and be there for them. But how much do we really have? The Addiction Center in Pleasantville, it's an amazing spot for people to go and try to get well. But do we need more of them? I think we need more. Can we afford to get more of them? That's for Dr. Haggie to speak about. The justice system itself we're taxed. The police, we're taxed. The criminal, the law courts are taxed. We're down in a situation we've talked about, it's been thought about in the province as a drug court. And maybe that's a good place for someone with addiction issues, that a drug court might be something that can help these people navigate through a criminal justice system as opposed to always ending up in jail a lot of times. Maybe treatment centers is a good option for this situation. And our social services, I have nothing but the highest praise. I worked a lot with the social workers from addiction services, and I sing their praises. But like anything else, they're taxed. And I've seen the social workers that are out dealing with home visits and child protection services, and the need for that's out there, and a lot of it's fueled by the amount of drugs we see in our society. So I just want to say thank you very much for the opportunity to speak here today.
Okay, thank you very much, Steve, for sharing your perspectives on societal trends and the types of drugs and opiates that we're seeing in our province. I'd now like to call upon the Minister of Health and Community Services, Dr. John Haggie, who will address the broad question of what initiatives are the province implementing to address the opiate crisis.
Hi, good afternoon. You've done very well. There's not too many people fidgeting, and I think that's probably a testament to my predecessors rather than anything else. I'm not hands-on and front line anymore, and so I hope this won't be too much of a contrast with what you've heard before. What I am going to talk about and the initiatives I'm going to talk about are, I'm just kind of the guy at the front. I'm the spokesperson. There's been a team of folk who are lurking around the room, some of them who have worked on this, some of them for their entire professional lives. So I wouldn't like you to think that this is all my doing, because it really isn't. But I'm proud to stand here and talk about what we've been able to get off the ground in the last slightly over 2 years. Just off script, the marijuana piece, which has cropped up with Steve and myself earlier on. This is a federal initiative. I think it's fair to say that every jurisdiction is on a degree of catch-up. And what I would say to you is that Newfoundland and Labrador is actually ahead of the pack when you compare ourselves with the jurisdictions that we know of, even in Atlantic Canada. So we'll be as ready as we can be. Whether that's enough, come back next year and see what Steve has to say then. I think one of the challenges, the space I work in is around policy. It's around dealing with how government as a representative of society deals with the issues it's presented with. We have essentially no issue with talking about physical health. If you have a broken arm or you have a bad cold or you have an illness, no one has any concerns really about sharing that in appropriate circles with friends. No one will do that with mental health. And that stigma and that silence has produced deaths as a result of it. If you think mental health is bad, then the Cinderella of mental health has to be the addiction side. That is even more stigmatized in a way. And to allude back to some of the comments that were made earlier on, our biggest numerical addiction is still alcohol. It still is numerically by far and away the worst. The challenge that we have with opioids is that because of the change in the national scene with the arrival of fentanyl, carfentanil and W18 and various other ones, it's become instantly lethal, whereas alcohol kills you more slowly. And as far as the treatment piece is concerned, I mean, nobody seems to question whether or not we should give nicotine replacement to smokers. No one questions whether or not we should be offering smokers cardiac bypass surgery or lung surgery. and yet for some reason the prescription of methadone or the delivery of psychology and counselling services to people with addictions is regarded somehow as enabling. And I think that's something you folk out there have to help me deal with. I can't do that by myself. So without further ado, these statistics differ from Steve's, and they do so because of the way we collect them, and that alone is a challenge. One of the pieces in here is that, and I'll allude to it later, is we actually have focused our efforts on the numerical piece. We had 57 hospital admissions involving opioids. That was not necessarily addictions related. We have a significant number of old folk who take their prescribed opioid, forget they've taken it, go take another one, forget they've taken that, and then end up on the floor after they've taken the third one. So it's not to be assumed that those are A, comprehensive, and B, simply reflective of drug misappropriation or addiction. We currently have 21 physicians prescribing either methadone or Suboxone. Suboxone was an initiative we put on open access probably 18 months ago. And as Trina alluded to, the ARNL, I'm sure I missed an M out there, have come on board with a training program for nurse practitioners. Health Canada's finally got the exemption piece, or is getting it sorted out for the methadone piece. So we have the possibility of rapidly expanding that group. Just as an aside, of the 21 physicians, we actually have 450 family physicians in the province. We have nigh 160 nurse practitioners. Addictions medicine is not popular within the disciplines themselves. Pharmacies, we have 1/3 of them, thereabouts, who will dispense either or both. We have 200 pharmacies currently in the province, so the number's around 60 when you total it up. We're still in the process of trying to wrestle with number collection. Steve has an in with the Office of the Chief Medical Examiner because that's actually housed in Justice and Public Safety. It's nothing to do with the Department of Health. So I can't get into there the way he can. And I don't have the badge anyway, or the blue lights. The current state of treatment is, it's evolved. It was never designed. It just cropped up over time. The bulk of primary care physicians in this province operate out of their offices and are essentially private subcontractors to the MCP services. We have an opioid treatment centre in Eastern Health, which offers some telehealth. Correctional facilities are done in a slightly different model, but sometime before the fall of this year, corrections facilities and the delivery of all healthcare services within corrections will be brought into the Department of Health, making us, I think, only the second or third jurisdiction in the country to do that. That will solve, I think, hopefully, some of the significant integration problems that you have when people are convicted and serve time and have issues with, in this context, methadone or Suboxone treatments. I think the rest of it there is fairly self-explanatory. I'm not going to read it to you. The management of an addiction really depends on 4 pillars. It's harm reduction, it's education, it's legislation, and it's treatment. And we've heard about some of those today. So looking at our initiatives, and they've kind of been arranged in a random order here, but they all mesh together. We have a situation whereby, for harm reduction, naloxone came out, and that came out first, and really that was the safety net piece. Because at the end of the day, if you can get naloxone kits widely distributed, you've got about 3 or 4 minutes after someone overdoses on a lethal amount of opioids before they're going to start suffering significant brain damage from respiratory arrest or slowing. So it's no good calling for an ambulance, because even in Metro, our response times are set at a standard of 9 minutes. That's not long enough. That's too long a period. So the naloxone take-home program saw just nigh 1,600 kits delivered. It's also been badged in a different way. We've partnered with the City of St. John's and any other community that wants it to do the pop-up tent piece. So that becomes an educational exercise. People can walk into these tents, There's a low barrier approach. It tries to get people talking about addictions. They can pick up a kit and get trained how to use it and walk out with it. And that, I hope, will be replicated over the course of this year as well. If you don't know where to get them, and there isn't a pop-up festival near you, 811 will be able to tell you if you can't be bothered Googling it or searching on the internet. We have a whole redesign project on the go with mental health as part of our implementation plan we announced in June, and I'll get round to some of that later. We have a mandatory safe prescribing course. All new physicians and nurse practitioners in the province getting a license for the first time have to do this course. We built this from scratch with MON and with help from the pharmacists and ARNL and the College of Physicians. In terms of treatment, we made Suboxone open access. There's no barrier from the system point of view to getting that. And we've got a working group which represents a whole variety of interests, including law enforcement, including community addiction specialists, and the like. So the legislation, again, our first piece was, in actual fact, was secure withdrawal management legislation. This is for youth. This is a very small group numerically, but they are incredibly difficult to deal with, or have been under current regulations and legislation. These are the people who cycle through community, they cycle through justice, they cycle through the correction system, and are really outside their parents' ability to control. We have an act that is as robust and as flexible as any in the country. We have a prescription monitoring program, and I wanted the naloxone out there first because one of the things this will do, and it's happened in BC, is it shuts down the prescription opioids quite effectively. It's no exaggeration to say that prescription opioid misuse or abuse, however you like to term it, begins with a prescription pad. And there's only a few people in this province who have them. That's not to say that everyone's doing this for malign or malicious intent, but I think we need to monitor, we need to educate, and we need to inform. A lot of physicians often don't realize how their practice stacks up to their peers. And we won't be comparing a family physician in Buckens with an addiction specialist in St. John's or vice versa. You'll be compared with your practice peers. So if you're worried about appropriate prescribing, you've no need to be. If you're worried that someone is going to come and simply take your pad away or report you to the college, that's not the case. But we all know there's diversion of opioids still going on, and people need to be aware of what their prescribing patterns are. And those are changing. Current opioid prescription guidelines altered last year after the national conference, and they are a lot better designed than they have ever been, with addictions in mind. One of the other things that is not listed on there, which isn't strictly related to addictions, is the need for pain clinics, the need for pain services. That's a demand reduction piece. You put people into an environment where their physical pain, for sure, can be managed in a far more diverse way without simply reaching for the Oxy-Neo pad, as it now is, then you will start to reduce the demand. And in actual fact, the other practical aspect of pain clinics is they have become the focus for deprescribing. They've realized the problems that they've started, and they have begun. You have people who spent their life managing pain who are now managing deprescribing, and they're providing education and updates for people in their peer group as to how to go about taking people off prescription opioids safely so you don't drive them to the fake heroin. The other bits in there are, again, building blocks, the connecting of all pharmacies to the pharmacy network. You couldn't have a prescription monitoring program until you got that in there. That's real time. You go and cash your prescription or fill your prescription downtown, and then you happen to have another one tucked in your back pocket, and you go 3 doors down and fill it again. Second person's going to turn around to you and say, hang on, you've just filled this up the road. And that activity will be flagged as well, because we're not just concentrating on prescribers with prescription monitoring. We're concentrating on pharmacies and people, because there are people who doctor shop or nurse practitioner shop. I'm terribly sorry. Don't wish to be isolationist or whatever the appropriate word is. So there's lots of wheels in this plan, and it's difficult to present them in a very linear fashion because they loop back and link with each other. There's a lot of moving parts to this. So this is a broad brush view of governance, and I know governance is a word that usually sends people to sleep, but the keys in here are on that left-hand block, and we've heard clearly about advice and input. Recovery Council is something new. It came out last June, and it's modeled on an idea I stole from BC. And basically what this is people with lived experience, either directly or through family, who sit and have direct access to that guy on the left there who's me. There's no filters, they're there. The Advisory Council represent advocacy groups or caregiver groups or healthcare providers who have a slightly different accent on it. And that mixing of the two is crucial for how we monitor the progress of the boxes as you go to the right. There is an implementation team, and there's 8 teams in actual fact, 7 of which are fully functional, 1 of which is in the process of going. I've highlighted the service redesign piece because that's our bit. That's the health authority piece. It actually is now no longer technically a health authority piece because they all report to a lady who's sitting in the audience here as Provincial Director of Mental Health. The idea there is that we will have a consistent standard, a consistent approach, and consistent leadership on the management of mental health and addictions across the province. The hands-on people are still in the RHAs, but the lines of reporting have already changed. So basically what we envisage, and again you have to accept that we are where we are, this is where we would like to go, and at some point we'll make the journey and it'll either be smooth and seamless or more realistically it'll be in fits and starts with hiccups along the way. We'd have a provincial centre of opioid dependence treatment. It's not biased towards the Avalon for any sinister reason, save for the fact that just about 48% of the population live on the Avalon, and that is where our critical mass is. That is also where we could engage academia, we can do some research, and there are resources there that aren't easily available in other areas of the province. You would have hubs based out from there. And I roughly envisage any major population centre, for example, on the TCH, anywhere which has a regional referral centre, for example, as a minimum. And that wouldn't be limited to that. And then outside those spokes, you would have people such as a practitioner working in a small group, ideally a primary healthcare team, and that's a whole other piece of transformational work we're working on. But that would be, for example, there's one community I've been to who says, we have a nurse practitioner, we have family doctors, we have a diabetic nurse, but our need is for an an addictions counsellor on, 2-3 half days a week. And when you add that in, that suddenly closes a gap. And that may be very specific to that community. It may not be related to anything other than a local demand. In another area, it may be more a seniors and diabetes issue. But we're trying to fashion it in context. One size doesn't fit all. The approach fits everywhere, but you might have a different flavor of pie when you bake it in the end. And the idea would be the primary healthcare ODT team would have access to a regional treatment centre. And just as an aside about wait times, since Hope Valley and the Grace and all of those others became operational, and we kind of streamlined the referral process, so it's a central intake, we've seen a significant reduction in wait times for some centres by as much as 50%. So it isn't perfect, but it's a lot better than it used to be. So the idea would be that it would build on the current model rather than replace it and start from the ground up. We need a case management approach. Folk need a central point of contact. And, in an ideal world, that would be a 24/7 point of contact. Again, we're moving from where we are at the moment. Mental health and addictions has by and large been regarded as an 8 to 4 Monday to Friday activity, and we know for a fact that doesn't work. There's a huge gap from 5 o'clock on a Friday night till 8 o'clock on a Monday morning. You can pinch hit, you can manage, you can patch something up between 5 o'clock on a Thursday night and 8 o'clock on a Friday morning. It's not really easy to do it over a weekend. So again, we'll take the low-hanging fruit and we'll deal with them the way we can. Again, harm reduction, recovery focused and client centered. Those were out there in our kind of principal document. There's 54 recommendations from the All-Party Committee. We have 18 short-term ones. 5 of them are done, and the other 13 are in progress and on target for our next report card, which is March. We have 3 that are left outstanding out of 54 on which nothing has yet been done. So I think when we've gone from 0 in June of this year, of last year rather, sorry, in the new year, we're moving faster than I can recall from where I used to work in healthcare, from a government perspective, than I can remember. Again, Suboxone, ideally the drug of choice, my experts tell me, particularly for young people, easier to use. It avoids the liquid handcuffs of the methadone approach and gets around a lot of concerns, much less likely to be diverted, much less likely to cause side effects. We are actually looking at other pharmaceutical options for treatment, but they are actually not yet available in Canada. But that's a discussion I'm having with my federal counterparts, because there are ways of getting around that if we can produce a degree of urgency. Multidisciplinary teams. Geography has been alluded to. You can't have a health science center in every community. We actually have, 100 and hang on, we've got 15 hospitals. That's it, 15 hospitals for a population that in Mississauga or Hamilton has 2. So we got to use technology. Telehealth, telemedicine was pioneered for psychiatry and mental health and is actually working well across the province for follow-up and even some initial consultations for those folk who've decided now is the time I want to address my substance use disorder. So that is a kind of confusing graphic, but essentially it shows that if you go in on the left-hand side, you filter through a variety of people and come out the right-hand side a lot better than you went in. That's the graphic. I was told to put something other than words in this, otherwise people would be asleep by now. You put the hub and scope model together, and what you've got is something Heather alluded to, care that's centered around the person, not the problem or a problem. It's not the gallbladder in 220 or the addict in 310. And it's closer to home, because one of the challenges is balancing removing people from a toxic environment where they're exposed again to kind of the drug culture, but also removing them away from the only supports they've maybe ever known, and trying to rebuild those relationships that they've often burnt on the way as they have gone down that rather nice jagged sawtooth that Steve showed in his graphic there. So again, comprehensive wraparound service. Are we there yet? No. We're nearer than we used to be. And again, moving from where we were to where we want to be. Harm reduction. You look at abstinence-based treatments. There's a city in Ohio called Portsmouth, which has a complete abstinence philosophy for various political and social reasons. The reason I chose it is exactly the same size as Corner Brook. And in one calendar year, with an abstinence insistence, they have had 4,000 deaths from fentanyl in a city the size of Corner Brook. Harm reduction works. The first time I ever came across that was talking to a guy. I actually had the privilege of going to the Supreme Court of Canada, talking about insight. And he came up to me from Vancouver and basically put his arm around me and said, I'm alive today because of the programs based around harm reduction. He hadn't quite sorted out his nicotine use yet, but that was a whole other issue. So we'll take one addiction at a time. Again, I've alluded to the supports. And often, things like housing and things like a kind of back-to-work rehabilitation program are part and parcel of the recovery piece. So it's not just about pills. It's not just about the medication. It's not just kind of the gallbladder, let's remove it kind of approach. A provincial centre of excellence is really what we need. building that is, I don't think we need a chair in addictions medicine. I think we need an academic lead. I think someone who's motivated and interested is probably far more important to the community than a title in many respects. But this would be the hub, the go-to place for expertise, for knowledge, for the difficult patient that as a clinician we always get. 90% of the time, most of the people will follow a fairly predictable path. But 5 or 10% of the time, whatever you try, falls apart. And these are the people who need that kind of wraparound expertise from someone who's been there a few years before, or may have seen it before, or has some new advice on the basis of research, and to keep that dialogue going. And that really speaks to the penultimate bullet. And the last one, we need to establish a desire and a willingness, and the people who are prepared to step up and do the leadership bit in what is the Cinderella of the Cinderella part of the healthcare service. And that's it. So thank you very much for your time. I hope I haven't run over. No one was waving frantically at me anyway.
So thank you to Minister Haggie for sharing many of the initiatives the province has implemented and will be implementing to address the opiate crisis. So the goal of today's education session was to further explore navigating the landscape of the opiate crisis in Newfoundland and Labrador. I think today really highlighted what healthcare professionals need to know. Thank you again to our panelists for their time and expertise. So to assist with planning for next year, I will ask you to complete an evaluation form for those that are in-house. And for those online, you can go to the Newfoundland Labrador Social Work Association and fill out the online evaluation. Share with us what you thought about today and what are some topics that we could talk about in the future. So for RNs that are in the room, you can come see myself or my colleagues here and get a continuing competency form completed. Licensed practical nurses as well can come down. And for social workers attending this session, you can claim 2 hours of CPE credits under the workshop category as per your professional education policy. So I'd like to thank you all for coming today. Thank you again to our panelists, and have a wonderful evening.